Really excited today to welcome Dr. Ahilan Sivaganesan, goes by Siva. I got to know Siva online through kind of our mutual posts on LinkedIn and our appreciation for value-based care. I would say Siva is a unicorn. I don't think I've met a lot of neurosurgeons that are into the topic of value-based care. And so it's going to be really exciting to hear about his thoughts on the topic. He's had a couple of really cool and viral posts on the topic of utilization management, which I know is a hot topic for everybody. And he has got a new role at a startup called Mishi, which we'll dive into. So really excited to welcome Siva, who is currently a spinal neurosurgeon at the Hospital for Special Surgery down in Naples, Florida. And welcome, and love to kind of just hear a little bit about your background and how you got down this path of spine surgery.
Oh yeah, well, thanks a lot for having me, Eric. Yeah, so I did college and med school in Houston at Rice, and then Baylor College of Medicine. Decided to go into neurosurgery. Did my residency training at Vanderbilt. That's where I got my initial sort of interest in outcomes, cost, and value. Vanderbilt had one of the first sort of outcomes registries for PROMs for spine in the country. And some of my mentors in the neurosurgery department there were really instrumental in setting that up. And I have a statistics background, and so it was a really fun opportunity to be able to play with that data and to use some of my background there for that. And so I did my residency training at Vanderbilt, and then I decided to do an orthopedic spine fellowship at HSS up in New York, and then kind of continued on this sort of track of doing this kind of research. And then spent my first 3 years in practice at Thomas Jefferson, and then just a year ago made the move down to Naples with this new HSS program. And yeah, that's sort of been my sort of professional career arc, and really been sort of interested in sort of measuring outcomes and costs and getting serious about value. And you're right, it's sort of when you have those kind of conversations with neurosurgical colleagues or department heads, sometimes you get a bit of like a glazed look. And so I think that's why it's so fun to have conversations like this with people like yourself.
Yeah, I will tell you, specialty care is an unmet need, and the neurosurgeons have not yet come to the table. So
Yeah.
you are the first of the legion. When you think about spine care, just kind of at high level, right? Do you think it's true? Are we over operating too much? Are we doing too much? Is it maybe it's not over operating, it's over injecting? Where are you seeing some of these trends that really is something that we need to dive into from a value-based perspective?
Yeah. I mean, I think there's two parallel problems on either end of the spectrum. I think any honest observer would have to admit that there is overutilization in spine care, not just on the surgical side, on the injection side as well. I think we don't love to say it, but I think it's a little bit part and parcel with fee for service. That if you're an employed orthopedic spine surgeon or neurosurgeon, you get reimbursed on RVUs. And the reimbursement for a laminectomy is maybe somewhere around 15 RVUs. The reimbursement for a one-level lumbar fusion maybe 50 RVUs. And now there's a gray zone. So sure, are there some bad apples where any honest broker would look at a scan and look at a patient's chart and say, wow, this patient should never have gotten surgery ever? I mean, sure, that happens, but I think that's pretty rare. I think what happens more often, though, is that there's equipoise clinically, where you're looking at a patient, maybe they have a grade 1 slip, a spondylolisthesis at L4-5, and they have, sciatica, lumbar radiculopathy, and you could make a case to do an outpatient decompression versus doing an inpatient reconstructive procedure, lumbar fusion. And you said, well, you know what? I want to reduce the risk of this slipped vertebra progressing. And so I'm just going to do a fusion up front. And you can kind of convince yourself of that. And sometimes that is the right answer. But the behavioral economics of the way we're paid definitely has a role. And I think it affects the utilization rate of things like spinal fusion. It also affects the underutilization of things like disc replacement or things like endoscopic spine procedures where there may not be a official code that's listed, or the RVUs for that procedure are significantly less than the sort of traditional workhorse fusion procedure. And so in that situation, it's very hard to, you gotta, if you're in private practice, you gotta keep the lights on. If you're an employed doc, you gotta hit your numbers as well. And so I think that's the challenge on one spectrum. On the other hand, though, I think there are a lot of patients that are stuck in this purgatory of never ending physical therapy or injections for 5 years. They're out of work. they're disabled, and if they were to get the right treatment at the right time, which may sometimes be surgery, and it goes well and they go back to work and they're a contributing member of society again, the true cost calculation of that sequence of events will be much more favorable than being stuck in this sort of no man's land of non-operative management, because either they're being told that surgery is a never event, or they just haven't gotten in front of the right provider.
I'm going to ask a follow-up question, and it'll be piggyback. It could be a little controversial,
Yeah,
and it may not be, but is there what's kind of gotten me? So you bring up this dichotomy of billing with a fusion versus decompression,
yeah,
and so for those that are listening, the fusion is when when you literally will have to fuse the bone together. You can use metal rods to do it. You could be uninstrumented, but the concept is that you're fusing spinal levels together, and the decompression is you're opening the space to the nerves, right? And
right,
I'm not a
right,
spine surgeon, but that's I think a
right.
good way to
It's
think
great.
about lay
Yeah,
perspective. But this happens all the time. The work needed to do let's say a very like minimal fusion, maybe a lot less than to do a very comprehensive decompression, but you're going to get paid much more to fuse.
right, right, right.
What's really so that alone shows that like, we're going to do what we're incentivized to do, right? So there's going to be a natural predisposition to maybe go towards a more higher paying procedure.
Mm-hmm, mm-hmm.
What has gotten me surprised, and I don't know if I'm just seeing a few cases of this online or if it's actually happening, are the pain procedures that are percutaneously inserting devices
Yeah,
that quote fuse,
yeah,
and pain procedure docs are doing 10 to 12 a day and they're getting fusion rates.
yeah.
I cannot think of a single
No,
scenario that makes sense.
yeah, yeah.
And
Thanks for bringing that
yeah,
up. That that
yeah.
that is like the hottest topic in our field right now. There's actually all the surgical spine societies got together and put out a joint statement saying that spinal arthrodesis or spinal fusion should only be done by spine surgeons, because you're right. There is this growing phenomenon of interventional pain doctors. So I call it CPT envy. That's what I wrote about in one of my. Where like I sort of imagine the pain doc sitting in their sort of clubhouse saying, those surgeons, like, why should they have a monopoly on all these juicy arthrodesis fusion CPT codes? We should be able to get in on that action. And so you're right. They have been starting to do percutaneous interspinous spacers. And they say that this achieves a spinal fusion, and they're using the same fusion codes that surgeons use. And the tragedy, look, it's like an old sort of pattern to say to have a turf war and to have a specialist say, you know what, only we should be able to do this. Like that's not anything exciting, right? Of course, a spine surgeon is going to say that, but there are so many situations where a patient would do well with an outpatient clean out procedure, a decompression where you're not putting any metal in their back, and instead they're getting a procedure with metal in their back that's being billed as a fusion. That's a travesty. And the interesting thing is that because the pain docs are upstream of us in the referral flow, they have sort of the sort of first right of refusal to offer that. And what's more interesting psychologically is that a pain doc has a therapeutic relationship with the patient that is built on the idea of avoiding surgery. And therefore, what they end up offering, even if it is surgery to us, doesn't seem like surgery to the patient because it comes from the same provider that's been giving them the gabapentin or giving them, an injection or whatnot. And so it's a real problem. Surgeons are complaining about this, but we haven't really gotten together to do anything meaningful, such as sort of go to the major payers and say, hey, look, we should check the NPI number and make sure that if these CPT codes are being billed for, it's from someone that has surgical training. And I think it also brings up a broader issue, though, and I think you and I think similarly on this, which is this whole concept of right treatment at the right time by the right provider is this deeper ethos that if we could crack the nut on that, a lot of these kind of issues would go by the wayside. It
Yeah,
just would never
absolutely.
make any sense for a patient to get an instrumented percutaneous fusion procedure by a pain doctor when there's a much better care pathway available, right? And so that gets to that deeper problem, I think.
And look, if I'm a patient and I have back pain and I'm told I can get a procedure, not a surgery, that does the same thing as surgery, which is, saying that this
Right.
fusion is the same, then of course I want to go for that one, right? Of
Yep.
course I want to go for the injection or the minimally invasive. And I would say this, I have not. seen any compelling data that is in favor of that practice of doing pain
Right.
procedures with fusions. But I would say if you're in a health plan, in a leadership role, in a clinical side, pop health side, and you're listening to this segment, I think do exactly what Siva said. Go look up your fusion codes and see what those taxonomy of those providers are. And if they are paying physicians, you need to kind of dig in a little bit.
Yeah.
And I'm not saying all pain docs do this. I'm not saying one should or not, but I will tell you that to do a pain management procedure and then bill as a fusion, I will go on that hill and say
Yeah. Yeah. Yeah.
that's probably not a good
Right.
thing.
Right. Right.
Um,
Right. Right.
so then,
Yeah.
this will kind of, you mentioned this topic of right care at the right time. So obviously we're working on that at Proterra. I know we're
Yeah.
going to hear about some stuff that you're working on too, but we're in a problem here where we have a cost issue. We know MSK costs a lot. We know spine costs a lot. Sometimes you break them up. There was a paper in JAMA that said the number of the top three cost drivers, one was spine and neck, and the second was ortho and joints. So
Mm-hmm.
that's really
Mm-hmm. Mm-hmm.
MSK, right? That's top
Yeah.
two or three.
Right.
Um, and we know that there's a lot of good actors and a couple of bad actors. So when we think about cost containment, obviously utilization management is something that has come up over and over again. You have had a couple very viral posts on UM. Tell me you know, what when did you know that those posts were going to go viral on
No.
LinkedIn? And like, what was your intention putting out there? Were you just venting some frustration about the system, or what happened? And what
Yeah.
what what did you learn from the process?
Yeah, I mean the first one where it was a patient that had critical lumbar stenosis. I mean, extreme nerve pinching. I wasn't even trying to do a fusion procedure. I just wanted to do an outpatient, unpinching, a decompression. And it got denied by a commercial payer. And this patient had done everything under the sun. And the payer was saying, well, you're saying that the patient did this, but we don't see documentation of it. We found the documentation. It was just such a like a distillation of the frustration that we have as specialists, getting such an illogical and infuriating no. Um, that yeah, I just instead of we joke as surgeons, we like to, especially in spine, we like to sort of publish our butterfly collection, like look at this great x-ray and like that kind of stuff. And I was like, this is something I know, we talk about this stuff all the time at the water cooler. Let me just put this out there. And yeah, it definitely got a lot of traction. And then interestingly, like a executive from that payer ended up calling me on my cell phone, which I wasn't sure how they got my cell phone, a few days later, and said, hey, look, what's the situation with this patient, how can we help or whatnot. Eventually got approved. But even that was a little bit odd. But yeah, I didn't really have any sort of grand scheme with it. But it definitely sort of hit a nerve, in terms of just like the flagrant sort of lack of consideration for like the basic intuition, Yeah.
Did you get like outreach not only from the payers exact, but like other folks in industry, other patients? Because it's a good example virality. It used to be that it depends on how many followers you have, right? So you get a bunch of
Yeah, right,
followers,
right, right,
but
right,
your
right, right.
comment, it's about this kind of interest-based algorithm that they talk about. So
Yeah,
it wasn't just you probably had all kind of different folks that are
yeah,
not in your social network reach out. So
right,
did you get
right, right,
any
right.
like inbound from all kinds of
Yeah,
different folks?
there were patients, that sort of had similar experiences, and I think they maybe have gotten this idea that, oh, okay, I'm like fighting for this patient, so maybe I can do something for them. I think that was like the idea there. Yeah, it was a nice sentiment. And then a lot of industry representatives, and I think because they know that sort of there's this dial that like they know that their implant volume or whatever else could maybe go up 30% if this
That's
sort of
so
problem was
funny.
sort of
That's so
solved, right?
funny.
And so they're like, oh, maybe he's onto something. um but yeah, I think it was something that was just sort of at the right time, and there was like a zeitgeist around it, I
But it
guess.
happened more than once. Didn't you have like a couple of them that went like
Yeah,
this?
yeah, there were a couple. Yeah. My wife joked that it's like if you're writing anything that is a complaint about the injustices of the commercial payers, like it's probably gonna do well. And I was like, I think that's probably right,
Yeah. It's and I will say this, and I do like to kind of couch this. So I think as docs, as providers, like providers, docs, clinicians, whatever you want to call it, there is an us versus them You
Yeah.
have the payer and you have the provider, and there's a zero-sum game. And what I learned, it's probably, through this journey is that like when we first start taking care of patients, we just assume that you have insurance company XYZ and they make money by you not having care, therefore they're
Right.
on the hook financially. But
Right.
then when you get into the nuts and bolts, it's so complicated that the risk-bearing entity could be a provider group, could be your system, could be your employer, could be a
Employer.
different employer, could be an ACO, could be a
Yes.
government, and the insurance company doesn't is actually trying to cut costs for their partners or shepherd that value. Who knows? And so we have this us versus them, but we don't even as providers understand that like how the money flows. We have no
Yeah.
idea. We don't know.
That's a
Yeah.
great point. And this is something that I have sort of tried to dig deep into in the last few months. It was not clear to me until recently that the majority of situations where patients have a employer sponsored health insurance, that the employer is the one bearing risk,
Yeah.
that the sort of self-funded self-insured model is now the dominant model. uh, it can be a bit of a tricky situation, because if a patient, say you're employed by Boeing, and you go in to get a visit, a checkup, and it'll say Cigna or Aetna on your card, but you may not realize that Boeing is actually the one cutting the checks and taking all the risk. And in that situation, the Cigna or the Aetna, they're what we call an ASO, administrative services only. So they are the administrative pass through. They are doing all that work, but the risk bearing entity is the employer. And you know, it's actually an incredible opportunity, because if you think about it, I'm sure this is what you deal with every day with Proterra, is that for the first time in a long time, the risk bearing entity has aligned incentives with the
Yeah.
patients and the docs. I mean, they want their employees to get back to work and be functioning members of the workforce. They want to lower their spend, but they don't want to lower it so much that the patients are disabled and on disability. And so that is for the longest time there was a lot of us versus them, but now you have this incredible alignment. And the other thing that's fascinating is that even the BUCAs, the Blue Crosses, the Uniteds, even they're not the ones that are actually executing the UM or the prior auth themselves either.
No, they're not.
They're outsourcing it to Evacor, or these other vendors who have their own incentives that are sometimes perverse. But there is this almost comical sort of game of telephone happening between this endless number of intermediaries, all which are trying to do a little bit of rent seeking, capture a little value, but providing no actual substance to the actual like care pathway.
It's
So, yeah,
and it's because we're not in a free market, right? So reimbursement is largely set. You have CMS setting the level,
yeah,
Medicaid,
right,
ACA is pegged to that, commercial is pegged to that. In a free market economy, you would have, let's say, Dr. Siva, world-renowned neurospine surgeon, will set his rate at X.
right,
Let's say new surgeon Joe Schmo is out of practice for 1 year, we'll set it at 0.6X.
yep,
Let's say you have your free clinic that does kind of
yeah,
free charity case scenario, we'll set it at 0.5X.
right,
We can't do that.
yeah,
And
yeah,
so
yeah,
what happens is this is a healthcare is a situation where there it's not only zero sum, it's like there are some times where everybody loses. You
yeah,
have declining reimbursement, so you have margins that were at 5% for healthcare
yep,
providers now down to zero or negative.
yep,
You've
yep,
got the payers who are now losing, you look at
yes,
GLP, now they're losing like
yes,
hundreds of millions or $1 billion.
right,
So they're in the
yep,
hole. And then you've got patients where their premiums, copays, all that stuff, cost share is going up. So there are no winners. I would actually say the winners, honestly, I think the winners are industry device, right? I think
yeah,
if you do a large fusion, your Medtronic or Globus or whoever your
yep,
rep
yep,
is
yep, yep,
getting
yep.
paid more than you are
Oh, there are
with
situations
no
routinely now
liability.
where, yeah, where they, yeah, yeah, yeah. Well, I would add one wrinkle to that, which is that in situations where the commercial carriers are not the risk bearing entities, they're doing wonderfully, right? Because they like ASOs, they also are having their margins come down a little bit. To your
Yep.
point, but this like hornet's nest of middlemen in between either the employer and the patient and the doc is is like frighteningly layered.
It's a
right? And
very
they're
tough
each
expression.
taking, I mean, like there's headlines every day now talking about how employers' healthcare costs are going up and up and up and up. And then you and your reimbursements and my reimbursements are going down.
Yeah,
And like at some point, this like the math isn't mathing, right? Like there
it's
is
not.
a whole segment industry sector that is sitting in between and responsible for a lot of the waste. You know, it's like the research passion that I had when I came out of training was around time-driven activity-based costing, and
Yeah,
it was inspired, as you know, inspired by Porter and Kaplan and their work, and what Dr. Bozic, who I know you interviewed, has been doing down in Austin. And I would do this, and I would do process mapping for a given surgical episode, and the whole idea was, okay, let's see, let's understand our true cost of executing a given surgery, and then let's see where we can match that with patient-reported outcomes and see where we can bring the cost down while maintaining the outcomes and improve value, right? You do that. And I realized over time, all I'm really doing is kind of improving the margins of the health system I work for, which is a valiant effort, but
yeah,
that's not really why I sort of get up in the morning. So then I thought, well, okay, what if we zoomed out and we did TDABC not for just a surgical episode, but for the entire care journey for a given condition, right? So you journey map a patient through their physical therapy chapter, through their series of injections. Then they go to see the surgeon. Maybe they get a surgery. They go back to PC. If you define a given time interval longitudinally, and you did TDABC in that sort of zoomed out bird's eye fashion, and then you tracked the incremental gains in patient-reported outcomes along the way, you could start to generate these sort of value streams quantitatively over time. And if you had a large health system and you could do this across a large population of patients with, say, lumbar radiculopathy or spinal stenosis, you would start to see this like incredible variation in both what we call, in sort of like the phenotypes of the different patterns of care that people are getting and the associated outcomes and costs. And I think that sort of zoomed out visualization of care pathways and associated outcomes and costs is the kind of thing that we need to do to really attack the problem of like and waste, because
yeah,
we might be surprised to find out, you mentioned this like earlier offline, but gosh, you know you do that over a 2-year period and you find out, well, like surgeon X over here in one of our satellite hospitals is intervening much faster in the care journey than the average surgeon in this
yeah,
population, and yet the total spend and sort of the time to achieve like a meaningful clinical benefit on patient-reported outcomes, like a MCID or what have you, say it's significantly faster at a lower spend. It breaks all of the sort of assumptions we have about conservative care versus surgical care. But you can only identify those sort of emergent observations if you have this sort of global view
yeah.
of practice patterns. So that's something that I think I would love to be able to sort of get to.
But I mean, so a couple of things. So we talk about utilization management, right? That variability of care is what now it's kind of like the same as you take your car to the mechanic, and if you don't know what's going on, they can tell you whatever
Yeah,
they need. And there's
yeah,
jokes about this all the time. Like, I don't know,
yeah,
sure, fix it.
yeah.
I don't know
Right,
what's, I don't want
right.
the car to just like explode. I'm driving
Yes,
because an
yes,
axle is
yes, yes.
misaligned.
Yeah.
But like the dirty truth is that we know in our community who the bad actor surgeons are.
Mm-hmm,
And
mm-hmm.
it's gotten to the point where like there is a hip arthroscopist in our geography, right? Not in my
Mm-hmm,
system, but
mm-hmm.
notoriously would put one anchor in, do a bunch of hip scopes, they're billing a ton of money for,
Yeah.
talk all these people into like stem cells. And like
Yes,
when
yes,
these
yes,
patients come
yeah.
see us for a second opinion, I can look, I know exactly who that person was, and I know they're overusing surgery. And we
Yep,
all know who they are. And so the
yep.
question is, how do the payers use utilization management more targeted, right? So like they're going to look at my surgical rate per patients per thousand. It's going to be way low because I'm very, 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 I
Mm-hmm,
push a lot of non-operative care. They're
mm-hmm.
going to see some others that are way higher, right? I think if you look at those surgical claims per thousand, you're going to get some sort of
Yeah,
data there.
yeah, yeah, yeah.
And I think that the other thing is when we think about this us versus them trying to break that mentality is that the one thing that's happened on this journey in Proterra, like I've probably now met with, and I've been very open about this, I've probably now met with like well over 100 health plans and then all their execs. And I'll tell you, there are, I'd say the default phenotype that I'm meeting on the other side of that proverbial table are people who really want the best patient care responsibly
Mm-hmm.
and to try to just figure out how we can balance this overuse and cost because costs are going up everywhere. Like, everyone's
Yes,
dealing with
yes,
it.
yes, yes, yes.
And I think that there is a lot more alignment than we think of, but we need to get, it works really well with the pay providers. I'm in a pay
Yeah.
provider, right? So
Yep,
where
yep,
you have
yep,
provider and payer aligned,
yep.
but I think the more we can do that, the better.
Yeah,
And there's certainly a case out there. So anyway, a little bit of an aside, but
yeah.
I think we're all more aligned because everything's broken for everybody. Nobody's
Right,
like, very few
right,
people are like
right.
really making out like bandits on
Yeah,
this.
yeah, right, right, right,
Yeah.
right, right. No, I think you're right.
Yeah. Tell me about the new role you have at the startup Michigan. And
Yeah,
yeah, because I
yeah. No,
want to hear about
thanks.
that.
Yeah, yeah. So Michi Health. So the way I got involved with that. So Sydney Haytoff is the founder and CEO. He has an incredible background where he was involved in the billing side for spine surgery practice for a long time. Then he was involved um, uh, on revenue cycle. He's sort of been in every sort of stakeholder position, and he started this company with his co-founder essentially to with a sort of an ambitious aim to eliminate the need for all the sort of layers of intermediaries that we're talking about and sort of create like a digital ecosystem that directly connects the employers with the docs in order to enable that kind of marketplace that we talk about. Now, I think there are a lot of entities and companies that use that kind of verbiage. But I think what a couple of things that are unique about Mishi is that they have really gone deep to sort of retool the entire tech stack to allow for this kind of direct connection between the employers and the docs. And what it has allowed, and what got me interested, is that we're now going to forward thinking, sort of value oriented practices in given clinical verticals and essentially doing pilot programs for value based care where those practices go at risk. So, a classic example is a nephrology practice in Texas that has been sort of quote unquote doing it the right way for years, where they're doing all sorts of high touch care and they're measuring sort of all the sort of long sort of downstream outcomes that matter for sort of total spend for nephrology. And they're doing all sorts of things that don't get paid for on fee for service, but they're doing it anyway because they want to achieve these gold star outcomes. But they haven't ever been in a reimbursement scheme that has sort of allowed them to truly flex those muscles. And so what we're doing with practices like that is saying, okay, let's design a truly longitudinally at risk VBC model. We're going to bring employers to you that are interested in this kind of at-risk model. We're going to define the kind of domain-specific clinical outcomes that matter and hold you to those, and then sort of do a pilot and then expand based on that. And I think that in and of itself is not an entirely new concept, but I do think employers are getting a little bit exhausted with the fragmentation right now. Like if you have a great outpatient surgery program for your employees, you might use Lantern. Or if you want to have great care navigation, you might use, Transcarent or Carum or something like that. But now you have all these point solutions, and there isn't really like a unifying operating system underneath
Mhm.
that can enable all these things. So that's what sort of got me interested and I also am like really obsessed with this idea of this sort of mapping out these care journeys over time. But to do that, you have to have a unification of the EMR data, the transaction data, and the financial data all in one place under one roof to really be able to do that and then quantify the costs and outcomes. And I think that requires this sort of like unifying operating system. So that's what Mishi is looking to do. They just partnered with Mark Cuban and Cost Plus Wellness. So they're sort of powering sort of the DIY version of Cost Plus Wellness that Cuban has launched. And so I think it's really exciting, and I think the opportunity to truly experiment on different forms of BBC, to have like a IPU in the cloud that is on the Mishi platform that then can try a certain at-risk model, and that different practices in a given vertical can actually compete on different forms of at-risk models and the outcomes and costs. I think that's it's something that is like hopefully inevitable, but we need like the transactional infrastructure to like make it possible.
And it so a couple points on that. Like so you and I think myself and there's a growing wave of surgeons who are experts in this area of value-based care that are now helping translate the theoretical,
Hmm.
here, like, so here's our book, right? That's the book we wrote
Yes,
on value-based
yes,
care. So can we
yes,
translate this
yes.
to the real world? And that's how it's
Right.
done through innovation. And I think the stuff that like what you're doing, what we're doing, that's how
Yeah.
we can translate that. If you look at the employer benefit space, and I know Cuban is all over this, is um, a lot of these innovation solutions, they're going to the employer. There's really two types, right? There's a clinical benefit and a
Hmm.
benefit, like a benefits grade
Hmm.
solution. They each have their place, right? So if you need a benefit for your workforce, you want to make them feel happy, they've got some stuff, great, turn on. But we can't confuse the two.
Yeah,
And I
yeah,
think what
yeah,
you
yeah,
guys are doing, from what I understand, is let's find the ones that are actually moving the needle, whether it's a
yeah.
provider,
Right.
solution, whatever it is, and
Yeah.
let's get that employer, if they want that clinical grade,
Yes,
to get them
yes,
there because the
yes.
benefits grades ones are already
Right.
being pitched by a bunch
I,
of
I
brokers.
think it's a good point. Like one example that sort of made it very grounding for me is that there was a uh, there was a single mom. She had an infant with a congenital heart defect. The pediatric cardiologist had recommended a certain a cadence of surveillance echoes and things like that, and the it was denied. But the single mom's employer was self funded, right? So Michi got involved and basically essentially bypassed the insurance denial, went to the employer and said, okay, look, this is the situation. We talked to a bunch of clinicians, and this is totally above board and totally natural to do this sort of. You're the payer. If you're willing to pay the normal in-network rate for it, we'll just create a direct connection between
Direct
you and the
conduit.
practice,
Yeah.
and just sort of ignore this denial.
The next question I have is, it's our last question, which I like to ask everybody is, looking back, you took the academic, you took the transformation, now you're doing it real life practice, and now you're doing it on the innovation side. So kind of looking back, I know a lot of us still, we got a long ways to go in our career, but what are you most kind of proud of looking back on what you've kind of done, especially bridging that gap from neurosurgery to value-based care? And then what are you most excited about for the road ahead?
If I have, with some of my writings, been able to sort of lift the veil a little bit on some of the inner workings of our healthcare sort of payments supply chain, I'm hopeful that will give all of us who are in the trenches a little bit more ammunition and understanding of, like, if you don't really understand how the system works, it's hard to make a dent in it. And so if I made a small contribution in that way, I think that would be nice. And in terms of what I'm excited about, like, I want us to be able to have a true market. Like, I think about this. I want us to have a true marketplace based on value. Like, we need to have that. If my mom, she lives in Cincinnati, if God forbid she needed a hip replacement, I'm kind of out of luck, even though I'm a physician and I'm a neurosurgeon and I have a lot of orthopedic friends. Like, I might ask my buddies in Cincinnati, but even they may not really know. Like, I want to be able to go online with my mom, pick the patient reported outcomes that matter most to her, and see a risk adjusted ranking of the providers and practices for a hip replacement relevant, vis-a-vis the patient reported outcomes that matter most to her,
Yeah.
right? And if there's a cost associated with that, and I can see that as well, like, I want that. I want that
Yeah.
for my mom.
People would pay for
And
it.
yeah, and like, we need a consumer reports for specialty care where you can pick what matters to you and then see, instead of just being, well, this person is in network and the driving distance is the shortest, so I guess I'll go to this person.
Yeah.
um, we deserve that. And even if that's a little bit uncomfortable for us as specialists to sort of be on blast like that, I liken it to sort of the checklist manifesto with Gawande,
Yeah.
where he would poll people about, like, do you need this checklist? Do you want this checklist? And surgeons would say no. And then they would say, if your loved one was getting surgery, would you want the checklist to be done? And
Of
they,
course,
almost all of
yes.
them said yes, right? It's
Yeah.
the same thing here. And so I'm enthusiastic about the idea that Michigan can help create a world where this kind of true marketplace exists, where you compete on value and not on volume. And I think if we can move in that direction, I think a lot of the frustrations we have will sort of inherently be solved because the underlying forces have been aligned in the right way.
Well, as a closing thought, if you look at the new CMS stars proposed rankings for 2027, 3x weight on improvement of physical and mental health and taking
Mm.
down weight of customer satisfaction metrics.